Welcome back to This Week in Immigration. I'm your host, Jack Malde, Associate Director at the Bipartisan Policy Center. In this week's episode, BPC Senior Advisor Theresa Cardinal and I talk about BPC's new report, Bridging the Gap, Meeting Workforce Needs Over the Next Decade. The report uses a data-driven approach to identify the occupations and industries at the highest risk of workforce shortages over the next decade, with healthcare leading the list. Then I interview Cassandra Zimmer-Wong, Immigration Policy Analyst at the Niskanen Center, about her report investigating how immigration reform can address healthcare workforce shortages. We've got data, economics, and policy reform in store for you, so stay tuned.
A strong workforce is the backbone of any thriving society, driving long-term prosperity while ensuring that the daily needs of millions of individuals are met. But the U.S. workforce faces significant challenges over the coming decade and beyond. Life expectancy is increasing and fertility rates are declining, causing the U.S. population to age rapidly. Baby boomers are retiring in droves, decreasing labor force participation and driving workforce shortages across the economy. Urgent and forward-looking policy action is required, but where are the priority areas for action? To help answer this question, I'm joined by Jack Malde, BPC's Associate Director for Immigration and Workforce Policy, who will be taking us through BPC's new report, Bridging the Gap, Meeting Workforce Needs Over the Next Decade. So, Jack, I get to welcome you as a podcast guest this week.
Great to be here, Theresa.
So, let's start with the basics. Can you explain what this report sets out to do and why BPC decided to work on this issue?
Yeah, so we are aware that there are some concerning long-term trends that are challenges to the US workforce. You covered the aging population. We're seeing life expectancy increase and fertility rates decline, which is driving declining labor force participation and introducing workforce shortages across the economy. It's also increasing demand in certain areas. So as we have more people who are over the age of 65, we will need strong workforces in areas such as health and social care to meet their needs, and in areas such as transportation, for example. Importantly, the aging population is a long-term trend that's set to continue for the foreseeable future. So the demands on the workforce will only get stronger, and we really need policy solutions. We need to act now. So with this report, we wanted to take that longer-term view into where the pinch points will be, so that we can address these issues before they become crises. A lot of research out there looks at, okay, where do we have current shortages? But we wanted to look a bit longer term at the trends and really implement forward-looking policy. We also wanted to get granularity on which specific industries and occupations are at most risk, so that we can inform very targeted policy interventions. So this report, I'll go into more detail on the exact approach, but we use a data-driven approach to identify the occupations and industries at greatest risk of shortage over the next decade. And we have some discussion about the policy approaches to address these shortage risks.
Yeah, so let's talk about this idea of workforce shortages. One of the things I remember when we were first talking about this is that there's some, I won't say division, but there's some discussion about whether or not a workforce shortage is a problem. Like, what is it? If the economy is running smoothly, why would we have shortages? Can't you just raise wages? All of these things. So let's talk about how we looked at defining a workforce shortage for this report and different things that might contribute to what we might call a workforce shortage.
Yeah, I think part of the issue is there's no universally agreed definition of a labor shortage. For this report, we're essentially defining it as when the demand for workers exceeds the supply available and willing to work at current conditions. And, as you alluded to, basic economic theory says that shortages shouldn't really exist, at least not for very long, because if demand exceeds supply, wages should rise, and more people should be willing to work at those higher wages. And essentially, that should mean that demand equals supply, and we say that the labor market will clear, and there's no shortage or no surplus. But in reality, I think there are various reasons why we might see more sustained shortages. One of them is, as we've already mentioned, the aging population. As we have a declining share of our population that is of working age, that is really a supply constraint, and rising wages cannot necessarily attract enough labor when you just don't have a strong working age population to start with. There's also the issue of long labor supply lead times. So if there's a particular occupation or industry that has a shortage and wages rise, it's not necessarily the case that overnight or very quickly that you're going to get more people into the area if there are strong or high barriers to entry. For example, you need like a 4-year degree, or you need some complex training to enter that area. So wages cannot necessarily attract that labor in immediately. We also see in certain labor markets regulation that prevents the market from acting freely. So, for example, in the case of direct care workers, Medicaid serves as the primary payer for long term services and supports, which can prevent wages from quickly responding to increases in demand. So, that's when another reason why you might see a more sustained shortage. And finally, we do see immobility of labor, whether it be geographic immobility or occupational immobility. So what I mean is, in theory, if wages rise in a certain occupation, you might see people enter that occupation, but for various reasons, it could be cultural, just individual preference. We don't see people. Well, in many cases, there is this sort of reluctance to change occupational industry. And certainly on a geographic level as well, there are significant barriers to moving. Maybe you want to stay because in the area you are in, because that's where your family is. And there are also cost issues with moving. So I think these are various reasons why we can see sustained shortages, and these motivate government policy to actually address the risk of shortages.
So, what is the approach that you took in the report to assess the occupations and industries that are the greatest risk of shortage over the next decade based on some of those criteria you just talked about?
Yeah, because there are so many reasons why you might see a sustained shortage, we wanted to draw on several data sources, look at several indicators on labor supply and labor demand going forward. So, firstly, we partner with the Burning Glass Institute, which is a nonprofit organization that specializes in data driven labor market research. So, Burning Glass has this labor shortage risk index, which combines multiple factors into a single index that gives essentially the level of shortage risk for different occupations and industries. So, for example, some of the factors the index includes projected demand in over the next decade for a particular occupation, which is from the Bureau of Labor Statistics. They also incorporate the share of workers in an occupation that is aged over 55. That can indicate how many people are we going to see retiring in the near future and leaving the labor force in that particular occupation, which obviously can increase the risk of shortage. They also have some indicators around barriers to entry. So the share of workers in an occupation that require or that have a job certification, that the more people that have job certification, that implies that there is this lead time to entering the occupation, and again, a greater risk of shortage if you have that sort of barrier to entry. And there are other indicators, and we outline them in the appendix of the report. But essentially, we get a comprehensive assessment of which areas are at greatest risk of shortage, specifically which occupations and industries. We also look at some other data. So, Burning Glass, again, they have analysis of real time job postings, and they provided some data on which degrees are required or lead to specific jobs. They have some data on which occupations have similar skills profiles to other occupations, which can indicate where retraining can happen. They also have data from job postings that indicate what do employers require for specific occupations in terms of education and experience. And finally, we look at some public data sets as well, for example, from the Bureau of Labor Statistics and the National Center for Education Statistics, to understand what have the trends been in terms of labor supply. So, for example, in specific areas, have we seen degree completions increase or decrease over the last 10 years? What have we seen happen to the number of foreign born workers in different areas over the last 10 years? And understanding that those labor supply trends is useful to see where do we need to have policy actions. So using all of this data gives us quite a comprehensive view of where we are likely to see shortages going forward.
So let's get to the results. What does the report say are the areas, the industry areas that are at greatest risk of shortage, and what are some of the occupations in those industries?
Yeah, so I think the key finding of the report, or the most important finding, is that healthcare and social assistance is the sector at greatest risk, uh, quite considerably. And this is because, again, as we mentioned, our aging population, as you have more and more people in retirement age and in their later years of life, we're going to need more health and social care workers to meet their needs. And also because a lot of healthcare occupations have educational requirements that act as barriers to entry. And just to give some specific occupations that we found to be at high risk of shortage: registered nurses, nurse practitioners, medical and health services managers, personal care and home health aides, and some healthcare adjacent occupations like medical equipment repairers. Those really came top of the list. It wasn't just healthcare, of course, that is at high risk. We also saw construction, installation, maintenance, and repair roles. These are dominated by older workers at the moment, so are set to see quite high retirement rates in the near future. They also see small or low rates of entry at the moment because of barriers to entry, because of significant certification requirements. So we've also seen transportation is an area that will see increased demand going forward. Also, as our population ages, we are likely to see greater transportation needs. And this might be surprising to some, but few areas that came out as high risk are some highly skilled college educated areas, including legal roles. We're set to see high retirement rates in the legal profession going in the near future. And also financial management occupations, we're likely to see increased demand in that area as well. But yeah, I think as I mentioned at the start, the area at greatest risk is really health and social care.
Yeah. So one area I didn't hear on that, but we're hearing a lot of conversation about is sort of STEM and technology workers. Where did they fall in the risk shortage area?
Yeah, a few of those occupations, a few of those STEM occupations did show up as having high risk, not quite on the same level as those areas that I just mentioned. I think this is in part because the workers in these areas are not as old as some of the other areas, so we're not likely to see as high retirement rates. We also see some potential for automation in some of these areas to help address potential shortages. So, for example, when you look at things like software development, data science, we're seeing AI really being very effective in these areas. So the STEM occupations didn't really come top of the list through Burning Glass's methodology. But I would say as well that just because there are other reasons why you want a strong STEM workforce, whether it be ensuring we're internationally competitive with China on technological development and AI development, to boost innovation, and also when you consider some of the fiscal impacts of a strong STEM workforce and STEM immigration. So I guess what I'm trying to say is just because an area being in shortage isn't the only reason why we should be looking at policies to strengthen the workforce in specific areas. So yeah, I think STEM is certainly an area that policymakers should have front of mind going forward as well.
So you said at the top that in addition to looking at the demand side, which is what you've been talking about mostly, we also look at labor supply trends, although some of that's included in the shortage index because you talk about like how many new entrants are coming in and how many people might be retiring. But in terms of labor supply, we're really thinking about who are the people that could be brought in to the occupation, right? So what did we find out when we looked at the labor supply trends?
Yeah, the most striking finding here was looking at degree completions over the past decade. And the data shows that despite the difficulties we are seeing and will see in healthcare, we have seen healthcare credential completions stagnate over the past 10 years. So from 2013 to 2023, we saw only a 2% increase in completions in healthcare. And this is concerning when you consider our aging population and the fact that we will need a lot more healthcare workers going forward. And digging into that, we saw significant declines in certain areas. So, medical clinical assistant completions have declined by 50% from 2013 to 2023. Licensed practical and vocational nurse training declined by 20%, and nursing assistant aides and patient care assistant aid completions declined by 22%. So obviously there have been some increases as well. The overall change in healthcare has been plus 2%, but it's really concerning to see some of those vital areas. So nursing is one of those areas at great risk of shortage, and we are seeing some declines in certain nursing credentials. So that indicates we need to be looking at policy approaches to actually increase the number of people completing education in these areas.
So, did we see any differences in terms of labor supply or shortages when we look at, for example, occupations or areas that require more education versus those that require less education?
Yeah, when you look at the sort of college educated occupations, they're very healthcare dominated. So a lot the occupations that really came top are things like nursing occupations, medical and health services managers, and nurse practitioners. When you look at the non college occupations, we do see some more variety. So, for example, shuttle drivers and chauffeurs in the transportation sector are at particularly high risk of shortage. Not only are we going to need more of these workers going forward because of our aging population, but we also see that a lot of the people are older in age, and so we're going to see high retirement rates. And also, when we look at the labor supply trends, so again, transportation, we've actually seen apprenticeship completions decline by 14% over the past 10 years. So that's to say that we do need to really have policy reforms across both college and non-college occupations.
So, after looking through all of this and getting all that data, what are the solutions? If these are priority areas for federal policymakers and other policymakers to focus on, what are some of the policy approaches that can be used to address these workforce shortage risks?
Yeah, so a key one that I've touched on is education and training. We do need to incentivize people to complete educational courses in these areas that we see as high risk of shortage. And there are various policy approaches that would be helpful. One that has bipartisan support is short term Pell. So, Pell grants provide need based financial aid to lower income students pursuing degree programs, but they don't currently cover most short term training programs. So, expanding the eligibility of Pell grants to shorter term programs can help increase completions in certain areas and help fill gaps in some of the areas that we've identified, such as nursing assistants. So, education and training is one. Immigration, obviously, this is an immigration podcast, and we're going to be delving into immigration a bit more in the second half of the episode. But I mean, immigration has to play a role as we see slowing workforce growth from US born workers due to our aging population. And our immigration system at the moment prioritizes family reunification over employment-based immigration. Certainly not saying that we reduce family based immigration, but we should look to certainly increase the rates of employment based immigration, whether that be through raising the visa caps that have been in place for over 30 years or other policy reforms. We also think that we need to look at the worker supports that we have. So, a significant barrier to work is caregiving responsibilities, especially for new parents and new mothers in particular. And they often decide to leave the workforce because they don't have the supports they need to stay. So, we need to look at things like childcare and paid family leave. The provision of these supports can help people stay employed even as they have a child, and this will be particularly effective in certain occupations that are female dominated. So, healthcare occupations, as we've outlined, are often female dominated. For example, 89% of nurse practitioners are female. So, some of these worker supports will be very effective in the areas that we've highlighted. And the final policy approach, and I do think we need to look across various approaches. The final one is automation, as I've mentioned. This can play a role in enhancing the productivity of workers, particularly those in high skilled white collar fields such as the legal sector and financial management. So I think we do have to look at investing in automation, obviously not to replace workers, but to enhance them and augment our current workforce.
So this is very interesting because it is, forward looking and you use a lot of different criteria. But what's missing from the research, do you think, after looking into all of this? What additional research and information do you think would be most helpful for workers looking to figure out where they should invest in their own skills and training, for employers that are looking to attract more people into their industries or occupations? What more do you think is needed for us to really design the best policy approaches here?
Yeah, there are a few questions that weren't really in scope for our report, but I think would be very useful for people to investigate. One of them is, why are we seeing such stagnating healthcare degree completions and the declines in some of those areas I mentioned? For example, medical and clinical assistants. Is it because people are not interested in training up in these areas? Is it because of non completions, which we know is a big issue generally? I think some more specific research into why we're not seeing growth in degree completions or educational completions in healthcare would be very useful. I also think I'd love to see people build on our research and think about specific policy recommendations that have bipartisan support that can address shortages in some of these specific occupations that we've highlighted and specific industries that we've highlighted. So, with regard to immigration, we're fortunate that we are going to be interviewing Cassandra Zimmer-Wong in the second half of this podcast. She's already done a deeper dive into how immigration can help address healthcare workforce shortages. And I'd love to see more specific reports on the healthcare workforce. How can automation be used to address shortages? What can we learn from other countries? For example, in Japan, I know that robotics has been implemented in nursing homes to enhance the productivity of care home and nursing home staff. So yeah, I just love to see research that builds on our report and dives into specific policy approaches that can be implemented with bipartisan support.
Anything else about the report that you want to mention before we sign off on this part?
Well, I would encourage people to read the whole report. There's a lot more in there that I have not been able to cover on this podcast. It's a data heavy report, but we do try and break it down pretty simply, and it is should be in the podcast description if people want to read it. And but yeah, I think that's everything. So, yeah, thanks so much for having me on, Theresa.
Well, thanks for taking us through that. As Jack mentioned, we're going to take a quick break. But when we come back, Jack is going to be interviewing Cassandra Zimmer-Wong, who's an immigration policy analyst at the Niskanen Center, about her report on immigration policy fixes for healthcare worker shortages. So stay tuned for that.
Welcome back. We now welcome to the podcast Cassandra Zimmer-Wong, who is an immigration policy analyst at the Niskanen Center, a DC-based nonpartisan think tank. Cassandra focuses on economic migration, legal immigration pathways, and refugee resettlement. Before joining Niskanen, she worked on the migration teams at the Center for Global Development and Labor Mobility Partnerships, or LAMP. She has additional work experience at Stanford University, the Organization of American States, the Inter-American Dialogue, and the U.S. Committee for Refugees and Immigrants. So welcome to the podcast, Cassandra.
Thank you so much for having me, Jack.
Great to have you. So we just spent the first half of this podcast talking about BPC's new report, and our research was completely agnostic about which industries would be at greatest risk of shortage over the next decade. But then the quantitative analysis clearly pointed to healthcare, and this was driven in large part by our aging population, increasing demand for healthcare services, but also the stringent requirements to enter many healthcare roles. Your research obviously highlights healthcare as well as a key area for policy focus. So I'd be interested to know, what brought you to the conclusion that healthcare is such an important area.
Yeah, thank you. So I think similar to you and your team, when myself and my team did the quantitative analysis on labor shortages throughout the US, healthcare keeps coming up over and over again. And we see a variety of healthcare occupations coming up over and over again. So on the quantitative side, I think we draw the same conclusions. But for me, I think the COVID pandemic really made it very clear for myself and I think for others just how vital and fragile our healthcare industry is. And without even having a policy or a research background, I feel that it's so clear that when you go to the doctor or the hospital or visit a loved one in a nursing home, that we're having some trouble with staffing throughout our healthcare industry. And when we talk about my report, I think it's also likewise so clear that immigration is already so central to our healthcare workforce functioning as it is today. So that's kind of what inspired me to visit this report in December. I show some 18% of our healthcare workforce already is made up by immigrants. So we know that immigration and healthcare are inextricably linked. These are two policy areas, research areas that are already overlap and are going to continue to overlap in the coming years and decades.
Absolutely. And you mentioned that certain occupations or professions keep coming up. So which ones do you see as particularly high risk of shortage?
Yeah, so I talk about a variety of different professions in my report, mostly broken down by the level of educational attainment needed to be licensed in that particular profession. But I can go through a couple that I think are really critical right now. So, at the highest level of education, you have physicians. The Association of American Medical Colleges today projects a shortage of 86,000 physicians by the year 2036, so within the next decade plus 1 year. So that's a huge shortage, and the shortage is across a variety of different specialties. So primary care, which is most significant, surgeons, and a variety of other specialties across the spectrum. Most of the shortage for physicians is driven by demographics. We have an aging population here in the US, but likewise, the physician workforce itself is aging. Lots of our current physicians are nearing retirement. So each year, our physician supply decreases while our demand is increasing. And further, and I think this is really critical, is the shortage that the AAMC projects for 2036 is only if we keep physician distribution and current staffing at the levels that we have today. But if we wanted to meet the needs of underserved communities and ensure that they're receiving the same rates and degree of care as well-served communities, we'd actually need another 202,000 physicians. So that's, I think, 6 times higher than current shortage estimates. So we're already underserving certain communities, rural communities, urban communities, tribal communities, unhoused populations in urban and rural areas. So if we want to ensure that they're receiving the same level of care as our well-served communities, we actually need an incredible amount of physicians within the next decade, and that is really coming through in the data. And then if I go on to some of the other professions that we highlight, I think myself and plenty of others have probably droned on in the past couple of years about nurses, but it's really true that nurses are the cornerstone of our healthcare system, and simultaneously we're seeing shortages of 78 some thousand registered nurses by the end of this year 2025, and then it'll grow to 63,000 plus by 2030. And at the same time, we're seeing that RN job openings are in the hundreds of thousands. So we have the demand today, we have shortages today, and our supply has been falling. Another area that I think is less discussed but also critical in the nursing world is nurse practitioners and other advanced practice registered nurses. So these individuals need a master's degree beyond their RN certification, but they really help fill gaps in primary care that we obviously see from physicians, and they fill gaps in other specialties such as midwives. So one APRN specialty is nurse midwives. We know that the US has alarming maternal mortality rates, and the trends are not looking great when we compare ourselves to our peers in the OECD. And these individuals can help fill those gaps. So I really do want to highlight that nurse practitioner shortages matter a lot. Another area that is widely discussed, I don't think I'm the first or the last person to say this, is in the area of personal care and home health aides. So we know that we have an aging population, and we also know that people want to age at home in the United States. Right now, we have some 5 million people working in direct care across individual homes, nursing homes, residential care facilities, but we need another 1 million more by the end of 2031. And we already have shortages that are between 150,000 to 350,000, and that will be between 2030 and 2040. For direct care, it's a little bit hard to quantify shortages because we don't have a national data collection system for the field. But I think what's really jarring is when you look at surveys of nursing home staffing today, so not even projections, we're seeing that some 54% of them have had to limit admissions due to staff shortages right now, and that there have been an average of 25% of patients who were referred to nursing care who are unable to secure a bed in facilities. So those shortages are really acute today and are going to unfortunately become more acute unless we start filling some of those gaps. And then the last profession that I really want to highlight that I think is pretty underdiscussed is EMTs and paramedics. So by the end of this decade, we will need 40,000 more EMTs and paramedics. We know turnover is extremely high in both of those professions. And it's so high that certain states today are lowering the age requirements for the profession to fill in these gaps. So certain states you can have 15-year-olds working as EMTs or paramedics. That's a really alarming statistic for myself. I think obviously teenagers deserve employment, but when we have high schoolers trying to fill in the jobs of full-time staff, that's alarming. We really need full-time EMTs and paramedics to keep our healthcare system functioning. So that is another area I think that's really important to focus on.
Yeah, thanks for taking us through that. I mean, those areas closely align with our findings too. Our report emphasizes, in particular, the nursing profession and the home and personal care aides. So yeah, that's good that we're sort of in agreement there. And I mean, you mentioned that meeting the needs of underserved populations, but what our report also looks at is, okay, we're going to have continuous aging of the population going forward, and we're going to have more and more people over the age of 65 that need care. We're not even meeting our needs now. It's only going to get worse without action. So you touched on this already, but why is immigration such a vital part of the solution to these shortages?
Yeah, I mean, I think there's a couple reasons for that. The first being that immigrant workers are already a critical part of our healthcare system. I mentioned earlier they make up 18% of the healthcare workforce overall today, but in certain occupations, they're already representing well more than that. So, physicians and surgeons, for example, immigrants make up 26% of that workforce. For RNs, it's 16%, and for home health aides, it's 40% today. So, we already know that immigration has de facto been a solution to our healthcare workforce and that these individuals are vital to our system functioning. But when we talk about filling gaps and expanding the supply of workers, there's a couple reasons immigration becomes an important solution. So the first is that we have in the United States today a huge pool of underutilized professionals who have been trained abroad who could be working in healthcare professions, but they're working in lower wage jobs or they're working outside of the healthcare field because of credentialing barriers. So we have the talent here, but they can't access the work. And then, second, I think the most important reason immigration becomes part of this healthcare shortage conversation is that international talent provides immediate relief. We know we have shortages right now. We know they're going to get worse without action. We can absolutely invest and we should invest in educating our future workforce in the US. We should invest in training and education. But if we want to fill gaps today, we need individuals who have already completed those requirements, who have already completed their education, who may even already have practical experience on the job. So, streamlining immigration pathways really helps us fill gaps right now. And we know that the need is right now.
Absolutely. Yeah, in our report, we emphasize we need various policy approaches. Immigration is essential, and as you say, can meet some of those shorter term needs. So let's move on to some of the reforms that you discuss in the report. Let's just go through them one by one, starting with the Doctors Act. So can you explain what that act would do and why it's so important?
Yeah, definitely. And I think, I guess before I go into all six, I would say that the reason that I feel we have to go through these six reforms is that our current system doesn't have visa pathways designated specifically for healthcare workers. So these individuals are competing with professionals in other sectors, and they don't have a streamlined pathway for them. So that creates a bottleneck and it creates shortages in our immigrant talent. And then we're already facing shortages on the workforce side. So it's kind of like a double edged sword. So our current system is, in my opinion, a little bit flawed and it's expensive and it's too slow to meet the demand that we have for foreign healthcare workers. And some of these reforms would help either speed it up, make it cheaper, or fix a flaw. So the first and the one that I personally feel most optimistic about is the Doctors Act. So this is a bicameral, bipartisan bill that would reallocate unused Conrad 30 waivers to states that have already met their quota. And that would allow more international medical graduates to work in underserved areas. So the Conrad 30 program is a program that allows each state in the US to retain up to 30 foreign trained physicians to work in underserved areas. Most of them are rural by bypassing the requirement that they return to their home country for 2 years. So, as medical students, they have a requirement to return home for 2 years before coming back to work. The Conrad 30 program allows 30 doctors per state to waive that requirement. But the thing is, not all states use all 30 slots. Only about 21 states used all 30 slots in fiscal year 2023. So we know that that's about 350 physician positions that have gone unused by states for a variety of reasons. So the Doctors Act would allow those 350 unused slots, the waivers, to be redistributed to states who have already hit 30 because Clearly, they have the demand, they have the open positions, and they have the need. That way, we're not increasing the amount of visas, we're not increasing the amount of expected immigration in this pathway, but we're making sure that every single slot that we have available for a physician is used. So that's one of the solutions.
I mean, the next one, I think you've kind of already mentioned, right? The credentialing of sidelined workers. So, can you take us through that one?
Sure. So the reason that I feel this is an important solution is that, as I mentioned, we have a workforce already in the US today that could be practicing in healthcare and to some degree that can't because of licensing. So there's about 270,000 immigrants in the US who fall in this category. They either have medical, like clinical medicine or health undergraduate degrees, and they're working below their skill level or they're entirely out of this workforce. It's a waste of talent because we have these individuals who have spent years on their education and training who are now working below that level because we are creating barriers for them. So, individual states in the US govern the licensing of medical professionals. Every state has unique requirements and unique exams. Some professions are more standardized across the nation, have more reciprocity than others, but the point being that there's 50 different ways to become a physician or a nurse or a phlebotomist in the United States, and that makes it very hard as an immigrant to be able to take your training from abroad and bring it here. So, several states have already started working through solutions to reduce these barriers. One of the ways to reduce barriers is to offer licenses regardless of immigration status. So, right now, most states only license individuals who have a social security number, but some states like California, Colorado, Illinois, Nevada, New Mexico have laws that allow individuals with an individual taxpayer identification number to be licensed. So that kind of takes away the barrier for some individuals. Other states like Arkansas, Nebraska, and New York will offer licensure to any individual who has work authorization in the US. So that allows people who have DACA status or temporary protected status, anybody who would have an EAD or employment authorization document to be licensed in their profession. So that allows states to access a much larger pool of talent. And then some other states have been doing more creative things. Colorado, for example, has a clinical readiness program that allows people who are international medical graduates to develop the skills that they need for residency. That can mean English language, that can mean cultural competency, just getting them up to speed with that last bit of training that you may not have gotten abroad, but that is required to practice in the US. Other states have kind of basic upskilling courses that allow migrants to both practice their English language abilities, but also fine tune some of the things that they need to get licensed for specific professions. So those are very promising. And then lastly, some states, just four right now, Tennessee, Illinois, Florida, and Virginia, have passed laws that allow international medical graduates to bypass medical residency requirements, which allows them an alternative pathway to getting their license to practice as a physician. So that removes a huge barrier. Practicing as a physician is, one of the most difficult licensure exams and in the United States. And this alternate pathway would allow a lot more individuals to practice. We know that other states have seen what these four have done and are introducing legislation to do the same. There's about 8 to 9 states that have considered passing this legislation because it's been successful in the other four. So that's very exciting.
So, would you like to see states sort of learning from other states about what works and implementing these solutions just on a broader scale?
Yeah, I think that would be definitely important. We know that with 50 different state boards of medicine, there's going to be a lot of variation in the way that individuals are licensed. But when it comes to international medical graduates in the immigration system, there's only one governing body for that, and that's at the federal level. So it's hard taking that high-level federal immigration system and then distilling it 50 different ways. So standardizing some of the practices, at least for international medical graduates, can help states learn from one another and then solve some of their own shortage problems and hopefully eliminate some of the disparity we see in states that are able to access these talent pools and the ones that aren't. So I think it's really important for states to see each other as testing grounds, see each other as ways to kind of test new policy solutions. And I think that there's a lot of knowledge sharing in this industry, and that feels very exciting to me.
Great. Well, let's move on. The third policy reform is again related to Conrad 30. I'll let you take us through that one.
Sure. So this one is a little bit more innovative, I guess I would say. So Conrad 30, as I mentioned, is a program that allows states to waive the home returning home requirement for physicians. These individuals, these physicians who have their home residency requirement waived, have a J1 visa. J1 visas, though, are not just for physicians. We already today have J1 category of J1 visas set aside for trainees. So those are non-clinical positions, meaning that you're not working hand on hand with a patient. But trainees can be people who work in medical transcription, occupational safety, medical records, pharmacy technicians, and other kind of non-patient interacting positions that are really critical to our healthcare system. So currently, J1 trainees, this program is pretty underutilized. Only about 10,000 people participated across 24 states in 2023, which feels like a huge gap to me. So, one of the things that myself and others at the Niskanen Institute have been talking about is replicating Conrad 30, but for J1 trainees, meaning that states could have a new pool of individuals who are already here, they already have a visa, they have been trained in whichever profession they've elected to train in that state. And this would allow a new track for them to remain in the United States and practice. Usually, it's about 18 months of practical occupational experience after completing the J1 trainee program. So it's not a permanent pathway, it's not a permanent solution, but it is an urgent one. So it can be immediately used. This has worked already very well for physicians. We know it's worked so well because we now have the Doctors Act that is trying to make sure we don't waste a single slot. So this is something that has not been proposed at the federal level yet. It's not in Congress, but I think could be a creative solution to fill some of these other gaps that fly under the radar a bit, some of the non-clinical roles.
Oh, that's great. Great to have some more innovative solutions. Learning that the Conrad 30 program is a good model that could be extended. Okay, well, moving on. The next one is au pairs for elder care. So take us through that one.
Sure. So currently, the US has a program also with the J1 visa that allows families to sponsor an immigrant worker for childcare. This is a pretty common program. We've had it for a couple decades. About 21,000 families a year participate in this. It allows American families to host an individual for 2 years in a work study type arrangement. So, individuals come to the United States, they're enrolled in some sort of higher education program, but they are also living with a family and completing childcare tasks. So, on top of helping a family with their children, they're gaining an education in the United States and practicing English language proficiency. So, this is a well utilized program for children. However, there is in some circles some discussion that we could expand this program for elder care. So the rules would be essentially the same. An individual would come for 2 years. They would be enrolled in an educational program outside of a home, but they would live with an American family, providing care to an elderly individual, perhaps with just tasks of daily living, maybe cooking, cleaning, whatever that individual may need to allow them to be independent and age at home. One thing that I think is really exciting about this is that the J1 au pair program was designed as a cultural exchange initially. The thought was that people would come from overseas to the US, they would gain not only their education, but kind of, a cultural competency in the United States, English language, things like that. The only downside is that gaining English language and cultural competency from a 1 or a 2-year-old is not always the easiest, right? But when you think about replicating this program with individuals who are 80 or 90, the wealth of cultural exchange, I think, only increases. And that feels like such a benefit, not only for the individual who is receiving the care, but also for individuals who are interested in coming to the United States, learning about our culture from our elders. I think that that's really exciting. So it really kind of enriches that cultural program that the State Department intended when they set this up. So this proposal would require amending the bill that created the J1 au pair program. But a lot of experts who have discussed this proposal really think that this would have bipartisan support. It feels kind of like a no-brainer to allow this program to just expand to different areas of care within a home. It feels like a very streamlined change. So while nobody has introduced this bill yet, I feel optimistic about this one.
Great. The next one is something that BPC's written about, but I'll let you take us through it. Schedule A reform. So, can you tell us what is Schedule A and how would you like to see it reformed?
Yeah, sure. So the Department of Labor has had a Schedule A shortage occupation list since 1965. The initial thought behind the creation of this list was that the Department of Labor would update the list at a regular cadence with occupations that were critical to the United States at that time, either because they were in shortage or for other domestic or foreign policy reasons. In theory, this was working, but unfortunately, the list has not been updated since 1991. And as of today, the 1991 list that we're still using only has nurses, physical therapists, and immigrants of exceptional ability on this list. So the Schedule A list was intended to streamline green cards, so a permanent pathway to work and residence in the United States. And nurses and physical therapists and immigrants of exceptional ability are critical to this day to the US. But we know that if this list was functioning the way that it should, we would have a lot more occupations that are shortage occupations today on it. And a lot of those occupations really need workers from outside of the US to be streamlined in. So, updating this list would take some work. The Department of Labor would have to be compelled to do so, and they would have to come up with a system that would allow the list to be updated at some sort of regular interval, and they would have to decide what qualifies as a shortage, what qualifies as a need. So there's a lot that would have to go into this to making it happen, but this is not an insurmountable task. And a lot of individuals, I know BPC has done a lot of work on this, predict that if the Schedule A list was updated today, there would be a lot more healthcare occupations on it. And a lot of the ones that we mentioned earlier in this segment would probably be included on the list. So that's physicians, that's surgeons, that's home health aid, would probably all be on the Schedule A list. And that would allow a streamlined green card pathway for those individuals. And that would allow them to avoid competing with all of the other individuals in all of the other sectors in the US, which we know green cards have caps, and that is creating, massive backlogs and wait lists for these individuals who we really need to be here today.
Yeah, and just to build on that, so if an occupation isn't on a list, then employers have to go through this process called permanent labor certification process to prove they couldn't find US workers to fill their role. So if an occupation's on this list, they can essentially bypass that process, which is very costly, time consuming. So yeah, as you say, BPC's written about this. We definitely think healthcare occupations would be prime for inclusion on this list. And just a bit of context as well, during the Biden administration, the Department of Labor did go out with an RFI, so request for information, asking people, how do you think this list should be updated? So there was this willingness to actually reform the list. BPC submitted our own comment to that RFI. Unfortunately, nothing came of it, and now we're in a new administration. But it was good to see that interest at the time. So hopefully that will revive. Okay, we got one more reform, green card recapture. So can you take us through that one?
Yeah, so in 1990, Congress established a cap on the number of green cards that would be issued in certain family based categories and all of the employment based categories. So, for the first time, starting in the 90s, we have now a cap on green cards. So, despite that, Congress intended for all of the green cards up to the cap to be used every year. And they had created a mechanism for the unused green cards to roll over from the employment based category to the family based category and vice versa. So essentially, there's a number of family based green cards each year and a number of employment green cards each year. If there's some left over in either category, that would be transferred to the other category for use the next year. That way, the number of immigrants and immigration levels stay the same, but we aren't wasting any slots. We know the demand is high. So, unfortunately, that system does not work in practice how it was intended. There's a pretty complicated formula used to calculate the rollover numbers, but essentially, in years when there is a high number of family based green cards, the formula works itself out such that no employment green cards roll over, leading to their permanent loss. So, as a result, we have a whole bunch of green cards that Congress intended for foreign workers. They have disappeared. And that also, in turn, leaves immigrants in line, and that line can last decades, up to 50 years even. So the idea of green card recapture is taking these green cards that would have been used for employment, should have been used for employment, recapturing them and using them for a specific purpose. So Congress obviously has the ability to fix the flawed formula and permanently prevent this from happening. But in the meantime, recapture could serve as a immediate solution while they work out the best way to either reformulate the cap or reinvent the system. So we've done this before. Congress has recaptured a limited number of green cards in the past for specific purposes. But if we did this for healthcare, for example, we have 220,000 unused green cards, at least as of December 2024. If we recaptured those and said we're going to allot these 200 some thousand green cards for healthcare workers, that would allow us to have 200 some thousand healthcare workers on a pathway to permanent residence in the US. This isn't a temporary solution. This would allow us to bolster our workforce by, almost 250,000 workers. That would be huge. So that feels like a no-brainer solution to me. These individuals were already, on the list to be here. We've allotted the space. We're not increasing immigration levels, and it would really help make a dent in some of these shortages that we have.
Absolutely. Yeah, BBC's written about the green card backlog and the economic cost of the green card backlog, which we estimate in the trillions of GDP uh, over 10 years. So, yeah, absolutely in favor of ensuring we can use more of our green card allowance. So, just to return to BBC's report, so we emphasize a few specific occupations, including registered nurses, nurse practitioners, personal care and home health aides. So I'm just wondering which of your reforms would actually be most effective in addressing shortages in those areas. I mean, the obvious one is Schedule A. You know, if you actually add those occupations to the list, that would be a very direct way of addressing shortages in those areas. But do you see any of the others as particularly effective for those occupations?
Yeah, I mean, I think Schedule A tops that list for me. Giving them a streamlined pathway is critical. I think green card recapture is kind of the blanket solution for all of these occupations. When you have a green card, you can work in any profession. You're here permanently, so that would solve shortages across the care spectrum. When you talk about nursing in particular and home health aides, the credentialing of sidelined workers or the brain waste that I mentioned earlier comes to mind. We know that there are individuals who have been trained in nursing or personal care or home care abroad who are in the United States with various immigration statuses who, if they were able to be credentialed and access those professions, would be able to jump in and perform today. So that's really critical. Those are reforms that can take place on the state level. We don't have to wait for Congress to act, and that would allow patients to be seen by these individuals as soon as their credentials are licensed.
Great. So, looking at the current policy landscape, do you see any of these reforms as particularly promising or politically viable in the near term?
Well, I think it's pretty hard at this point in April 2025 to really predict anything in immigration policy. So that remains to be seen. But I will say, I think the Doctors Act feels the most politically viable right now in this moment. We know that it's been introduced as a bill. We know it's bipartisan, bicameral. It's gained traction, and people are talking about it in immigration policy circles. People are talking about it in healthcare policy circles. People are talking about it on the Hill. We have momentum on the Doctors Act, so I really do think that something could come of that in this administration. We also know that right now states are developing their own policies for licensing, credentialing to deal with international medical graduates and to deal with individuals from abroad who are seeking to enter residency in their states. So I do feel really optimistic that regardless of what's happening at the federal level, states are going to continue to make these reforms, even if it's at the smallest kind of increasing English language classes, increasing upskilling courses for some of these non-clinical healthcare professional roles. I feel really optimistic about that, and I think that states are watching what each other are doing and are eager to reform what they can, whether it's in healthcare or immigration policy. And I think that we'll probably see a lot more of the state level work being done in the next couple of years.
Yeah, and you mentioned this. Some of your reforms, they are just ensuring that we use the allowances that are already there and that we don't fall short of those existing allowances. So, I mean, a lot of these seem like no-brainers to me, and I'm sure will have clear bipartisan support. So, yeah, I think we've covered those reforms. Is there anything else you'd like to say about your work or the report?
I mean, I think I've really appreciated the way we've covered all six of the ideas. I think that the only thing I would add is we need to be, as immigration policy researchers, analysts, scholars, talking to our healthcare colleagues a lot more. They have some really great ideas. They know what it's like dealing with the system in practice. They know what it's like dealing with visas and licensing and getting individuals employed and retaining them in their hospitals, in their clinics. So I really do think it's important that we keep communication lines open. There's some really great ideas coming from both the immigration and the healthcare policy spaces. And with a little bit more collaboration, I think that we can get even more momentum on some of these other solutions.
Yeah, completely agreed with that. And your report, so it's Immigration as a Solution to Healthcare Workforce Shortages, which you wrote as part of the Niskanen Center. So we'll include a link to that in our description. But yeah, thanks, Cassandra, for coming on. It's been great talking to you.
Yeah, thanks so much, Jack.
And that's a wrap on this episode of This Week in Immigration. Stay tuned for our next episode in 2 weeks. In the meantime, one last reminder to subscribe, rate, and review this podcast on Apple Podcasts, Spotify, or your favorite podcast platform, and share it with your friends and colleagues. You can also find more information on all the issues we discuss here on the show at bipartisanpolicy.org/immigration. You can follow the Bipartisan Policy Center on the X platform at BPC_bipartisan. You can follow Theresa Cardinal Brown at BPC_T Brown, and you can follow me at Jack Malde. Send your comments and feedback to us by email to immigration@bipartisanpolicy.org. I'm Jack Malde. This Week in Immigration was created and executive produced by Theresa Cardinal Brown. This episode was written by myself, Theresa Cardinal Brown, and Diana Wang. Joshua Joe is our audio editor. Talk to you next time on This Week in Immigration.